740, okay. Progesterone, we have creams, we have sustained release capsules, we have lozenges that go under the tongue, suppositories, IM injections. Like I said, this is very, very inexpensive stuff. There is no financial reason why this is being overlooked, none whatsoever. Now for the men, I think, I'm sure this is going to be much shorter, but same sort of situation. Our mindset is, don't do testosterone because you're going to get prostate cancer. We're not seeing that. Incidence of prostate cancer, you get to 50, 45, your incidence start to increase. They say by the time a male gets to a certain age, every male has prostate cancer. But it's the decline in the testosterone. Look how it correlates with your testosterone. So if you look at nothing else, it's kind of like in females with, some of those studies. If you look at nothing else but as a guy starts to lose his testosterone, the increase of prostate cancer increases. It's that perfect, that perfect bifurcating graph that something's up, and this is what the researchers have been clinging to. Prostate cancer spending, almost $300 million a year, the cost of treatment. Testosterone effects, both male and female. Females only produce like 1/3 of a milligram a day. Males, much more. But for the male, and the female too, whatever you would associate with strong bones, strong muscles, sense of well-being, sexual and reproduction function. Testosterone depletion. As we get older, we're going to produce less testosterone. Stress, just like females with progesterone, the more stress a male is under, the lower his testosterone is going to be. And again, it's called that pregnenolone, that starting point is called a pregnenolone steal. Patients that suffer from chronic back pain, that's that perfect daily aching pain that lowers testosterone levels. And one of the problems is if you start getting muscle wasting, one of the first places a muscle starts to waste, or as we get older, is those two backstrap muscles that go up the spine and support the spine. So the lower the testosterone in a male with back pain, the worse the worse his pain's going to get. Abraham Morgentaler, Harvard Medical School, one of the articles that I have in the pamphlet. He founded Boston, a research center. If you get the time to read it, the whole notion that men should be castrated if they develop prostate cancer was developed in the 1960s. He explains how he goes down into the basement of the archives and pulls out the original data and the original paperwork. And he looks at it, and in the article he's explaining how his heart starts pounding when he realizes that this Nobel Prize winning researcher based his findings on what eventually was, when you eliminated what was already skewed, was based on one patient. And like 3 of the others that weren't even listed on it, weren't even counted. And so if you have the opportunity to read that, go online, Google this individual, and read that article. So if you take testosterone, you're going to get prostate cancer? That's a question, and that's the answer that most males get. There was a study done, many studies. Physicians' Health Study, the Baltimore Longitudinal Study, the Massachusetts Male Aging Study. It involved tens of thousands of men, and they followed them for 15 years. It did not show a correlation between prostate cancer and total testosterone. A collaborative review. This involved many countries. Germany, Harvard Medical, I'm sure Morgentaler was involved in that. Brussels, University of California, Milan, Italy, Ontario, Canada. They got together in a room and they searched all the data, every article, review that they could find. Their conclusion, the literature strongly suggests that testosterone therapy neither increases the risk of prostate cancer diagnosis in normal men, nor causes reoccurrence in men who've been successfully treated with prostate cancer. The review substantiated the saturation model for testosterone. This does not include advanced stages of prostate cancer. We know for sure if you take testosterone and you have advanced stages of prostate cancer, chances are it's gone somewhere else. Testosterone is going to stimulate the growth of that. We're talking about what has been localized in the prostate gland. The saturation model that this review substantiated very simply states that the prostate gland which, by the way, in the male is the equivalent of the uterus in the female. The prostate gland has as much testosterone, and it doesn't matter how much you lower, you would almost have to filter out a male's blood in order to get the level of testosterone in the prostate to diminish to a significant amount, called the saturation. So it doesn't matter. It already has as much as. So if you take testosterone, it's not going to matter. It's not going to affect the prostate. It already has as much as it can hold. Okay. And the same with DHT levels. DHT is another form of testosterone that happens to be more potent. So here's the other question. Well, if I'm diagnosed with prostate cancer, would I want my testosterone levels to be high or low? And this is at Nobel Prize winning, where you want to lower the levels. Well, how would my outcome be, my survival rate, and how would that correlate with my testosterone levels? In some of the research, Harvard Medical, 13 testosterone deficient men, they would follow them for 2.5 years. They increased their testosterone levels from 230 up to 664. They didn't see any increase in the PSA. PSA, by the way, is the blood that measures the prostate activity. They didn't see any growth, any enlargement. They didn't see any that the cancer had spread anywhere else. Their conclusion, the long-standing prohibition against testosterone therapy in men with untreated or low-risk PCA merits reevaluation. Austria, 156 men. The average man had a 7.4 PSA score. The Gleason score here, once you're originally diagnosed with prostate cancer, Gleason score is like, look under the microscope and they'll say, okay, of the prostate gland, the biopsy, they got 50% of them are nasty. The other 50 aren't so nasty, and they come up with these numbers. And it goes from, Doc, can you help me with that one there? Is it 0 to 10?
Yeah, and the higher the number, the worse it is.
The higher the number, the worse the outcome. Testosterone levels for those that had prostate cancer, if that T level was a 4.1, their Gleason score was 5 or less. If the testosterone levels got down to 2.8, their Gleason scores went up above 8. Japanese research study involved 272 patients. Testosterone level, the lower the testosterone level, the less the 5-year outcome looked for the particular patient, 68% to 85%. Another Harvard Medical, 117 patients that were diagnosed with prostate cancer. When they did the biopsies, the 47% of the patients that were biopsied had active if their testosterone was low, 28% of them if they had normal testosterone. The Gleason score was above 8 for every patient that had low T. Things to consider. If it is in fact true that testosterone increases the risk of prostate cancer, and if it excites the growth of it, autopsy studies show that 8% of men in their 20s died for whatever reason, and have had autopsies, and 8% of that population has a small prostate cancer. So that's when their testosterone's highest. So you would think it'd really be stimulating that cancer to grow. Testosterone does not change the BPH symptoms. That's questionable there. I mean, that's one of those things that you almost have to get online and Google and get some more information on that. And again, prostate cancer incidence increases with age as testosterone levels fall.